If you're building in behavioral health, the biggest care gap isn't in the therapist's office, it's everywhere else. The majority of behavioral health needs surface in primary care, oncology, and maternity wards, settings with no efficient or scalable way to identify, assess, and refer patients who need help. Today's guest is the one building that solution. Chris Molaro is the co-founder and CEO of NeuroFlow, the market leader in behavioral health technology infrastructure with over $50 million raised and 4 acquisitions in 2 years, including Owl Health, Intermountain Health's proprietary behavioral health analytics model, and value-based care enablement company Quartet Health. NeuroFlow's AI-powered platform identifies, risk stratifies, and manages behavioral health in any care setting, serving national payers, health systems, and the federal government. Before NeuroFlow, Chris graduated from West Point and served 5 years in the U.S. Army, including a tour in Iraq as a platoon leader, an experience that showed him firsthand how the system fails the people who need it most. Chris was simply amazing, and it was such a privilege to learn from him. Chris, it's amazing to have you on the pod, so thank you so much for being here today.
Thanks for having me, Vic.
Yeah, so you have such an amazing background. I mean, you were in the military before and now you're in healthcare. I bet a lot of people you speak to, it sounds like a very unconventional thing to do. I wanted to kind of start with when you were in the military, what were those common lessons that you learned as a soldier? And how does that those specific lessons that you learned kind of help as being a founder overall?
Yeah, Vic, I was so naive when starting a healthcare company that I thought healthcare, you can learn it just like anything else. And I thought this was going to be, in hindsight, a lot easier than it's turned out to be, just because of how convoluted our healthcare system is and how it changes with policy changes and so forth. But since 9 years starting the company, I started the company as a healthcare outsider, and I think whether I want to admit it or not, I'm an insider at this point. Working with health plans and health systems around the country. That said, I didn't know this at the time, but my undergrad is from West Point, and that was my commissioning source into the Army. But in hindsight, it's become so clear that the parallels behind military service and the leadership training that they provided us is more overlap than you think with entrepreneurship. To me, every day I pull on the experiences, the lessons learned, and so forth that I had the benefit of learning experiencing when I wore the uniform. And I'll just give you, for example, when I was a platoon leader, I was a second lieutenant and first lieutenant, led a platoon of 40 soldiers in combat for 12 months. And on our combat missions, no one was giving us a script of what to do. They said, here's the goal, here's the mission, here's the intent, here's the situation, where we think the enemy is, how much fuel we have, what resources we have on station. And then you'd have to figure it out. And you figure it out with the men and women that was in your unit. And when you were on mission, things would happen all the time that you weren't expecting. And you had to adjust on the fly. And you had to, operate without perfect information, with finite resources, and you did that as a team. And if you didn't, the stakes could be life or death, literally. So, now you fast forward when I'm starting NeuroFlow, no one gave us a playbook on how to do this. No, that's okay. No one gave us a playbook on how to do this. Nobody, we had finite resources, definitely, right? We didn't have really any money in the bank. We had to figure it out along the way. Every week, every day, there were challenges that surprised us, whether that was a new competitor, a teammate leaving, a bug in the software that we had to react to and adjust to. And we had to do it as a team. And if you don't do it, the stakes are, you could go out of business. And so to me, leadership is leadership. It doesn't matter if you're leading in combat or leading in the boardroom, and people are people. And so I've really tried to take the best of my experiences from the military and apply that to NeuroFlow, and I think for the most part, it's been really successful.
I mean, there's a big correlation with what you're building in behavioral health and in the military. And I know you have a lot of partnerships when it comes to the military for mental health, for those in combat to focus on potential suicide warnings and all of that amazing stuff that you guys do. Why did you kind of decide to specifically, go and build more in the infrastructure level of behavioral health? What did you find specifically in that problem versus just making a random app for soldiers or for patients to use?
I'd say another way that we could have gone was another like teletherapy group or provider group and so forth, right? So absolutely the app or that. And when we dug into it and we actually started to learn a lot about what the problems were, there when we started in 2017, 2018, the headline was always access is a big issue. We have a provider shortage. There's counties in this country that don't have psychiatrists. All of that is true. But then the question was, well, how do you solve that? And, when you look at the supply demand inequity of how many people need mental health services and how many providers are there, you can't hire enough quick enough to fill that void. And, as far as an app goes, a mobile application can be the right solution for right people, but it's not a silver bullet. And there's a ton of people that need mental health support that may not have access to smartphones. So then an app wouldn't be able to touch them. And so what we did was we looked at how can we use the existing resources that we have, the existing therapists, the existing networks of psychiatrists and therapists and the different content app providers out there, and use those existing resources in a more intelligent and scalable way. And that's where the infrastructure place comes into play. So if I could say, we're going to get the highest risk people to this part, and then moderate risk people to therapy, and lower risk people to a digital self-service tool, we now are solving that access issue by using the resources more intelligently. So it's just another way to skin the cat. And the good thing is, I don't think any one solution is a silver bullet. Like, we need those teletherapy and those network providers, right? But but we thought that the infrastructure play differentiated ourselves in the market and solved a real core issue.
You brought up a great point there where it comes down to figuring out who could be in risk for at the most perfect time. And I feel like that could have been a struggle at the beginning when you guys were starting. Like, how can we find these people? How are they going to use our solution to benefit themselves? What did you learn from the beginning of starting NeuroFlow when it comes to finding these patients? And what are you doing now differently?
So when we first started NeuroFlow, I'm talking early days, our core customer that we partnered with were providing the technology infrastructure to work with therapists and psychiatrists so they could better engage their patients throughout care and measure outcomes throughout care. And it was working well, but what we realized, 2 years into the journey, were anybody that's already in therapy or seeing a psychiatrist is already getting care. So they're not falling through the gap of care. There's the vast majority of people that have a mental health diagnosis. Well, either they're not diagnosed and they should be, or they are diagnosed and they actually don't follow up and get that care. And so we went upstream, not to sell to therapists and psychiatrists, but to go to where the vast majority of people are. So primary care, OBGYN, pediatrician, nephrology clinics, oncology clinics, where people were getting their physical health treated, and they may showcase mental health needs, but weren't actually getting those treated. And so going to those physical health providers, we gave them the tools, the assessments to better understand the mental health needs of their patients and then route them to that mental health care. And so that was a lesson learned for us, so that we went upstream. You just look at the data, the vast majority, I'm talking like 80% of antidepressants in this country are written by primary care providers, not mental health providers. And
Wow.
so, yeah, exactly. And those people are people that typically fall through the gaps in care and don't follow through and actually getting their mental health challenges solved. And, that's the lane that we play in today.
Yeah, one of the biggest things that I feel like is very interesting is that, it's very easy to say, okay, we're going to go direct to consumer. But one thing that you guys did specifically is let's go directly to the providers. And you were kind of mentioning about how important it is for providers to get the solution. It was really interesting to me. Like, how did you guys figure out who your first provider group was going to be, and how did you get in network with them, kind of tell them, trust us, this is a solution that could potentially benefit your patients, yourselves, and everyone involved?
So first, starting with the therapists and the psychiatrists that we worked with, I mean, they were literally small mom and pop mental health providers here in Philadelphia that we knocked on doors, and rather than trying to sell them, NeuroFlow and get them to sign up for our tech platform, we asked questions. So we're like, what are your challenges in your workflow? What if you had a magic wand, what problems would you solve for yourself and your patients today? And we just went on a listening tour. So rather than trying to solve a fictitious problem or something we thought was a problem, we asked them what their challenges and problems were. Like health systems, OBGYN, primary care. It's, how do you identify mental health today? How do you treat mental health today? But what are the options that you give your patients? And we would get answers like either I don't ask the question because I don't know what to do, or yeah, I'll give them the depression assessment. And if they score positive, I'll give them a card with some phone numbers on it, and I'll say, you could call this to get an appointment with a mental health provider. And, you know, again, the vast majority of people that are referred to behavioral health don't follow up with that care. And so it was about going to them, hearing them out, learning what their challenges were, and then solving their challenges rather than trying to sell them another widget. Does that make sense?
That makes a lot of sense. And I think that's such an important aspect because a lot of founders now, I see a lot of founders focusing a lot in behavioral health. It's a very, I guess, hot topic. A lot of people at post-COVID now are talking about it. What, was the actual white space that you had to figure out at the beginning of the year? And what do you think are the current white spaces in behavioral health right now? And that can be from patient side, payer side, or the provider side, or where do you think there's still significant gaps?
I mean, if you look at there's several. I mean, which is both exciting from an opportunity standpoint and frustrating from like a mission standpoint because we still have 60% of people that have mental health diagnosis don't get it treated today. It's like imagine if we said that same stat for people that had cancer. 60% of people that have cancer don't get it treated. That would be a national emergency, but that's accepted as a standard in the mental health space. Likewise, 20% of mental health providers actually measure outcomes objectively today. And, they're like, oh, I'm good enough. I know my patients better than anybody. I don't have to measure anything. But again, imagine if a nephrologist said that about their patient's diabetes and they didn't measure their A1C level, you know? And so that level of, rigor and objectivity is something that really needs to change in mental health so that we can get people better and not spend in perpetuity to just, you know, have somebody be in therapy for the rest of their life, but actually get them better. And that's where a combination of data and analytics, technology, payment and incentives, and the right tools need to come together to drive that change.
Yeah, I think one thing kind of talking in the provider kind of aspect here that might be and this kind of goes to your newest kind of data that you guys kind of got on suicide risk analysis and risk detection is like how accurate is it, right? Like, it's very high stakes. These are patients who are obviously, they're definitely, very emotionally feeling very discharged. How on the provider state of point, how are you guys kind of flagging those risks accurately and kind of in the same time making sure that you guys are helping those patients as much as possible?
I'll answer this question in two parts. One, actually, how we're doing that today, and then an interesting story about overcoming a growth obstacle for us in this regard. Exactly, I think, which is a good story. So we're addressing the suicide ideation identification in a few different ways. There's a lot of standard evidence-based assessments that are delivered today that are not made up by NeuroFlow. These are accepted as medical, the gold standard in the medical community. One example is the PHQ-9 depression assessment, and just 9 questions that the patient is asked, and then it's scored on a certain severity level. That ninth question asks the patient directly about thoughts of self-harm or harm of others. So if that question is answered positively at any degree, that's an immediate flag of a suicide ideation. And you'd be surprised at how many people answer positively on that, especially when the question is delivered through a digital means like we do before the appointment, so that they're not like in the waiting room filling this out where maybe you're more conservative in your answers and you're not as willing to be honest, right? So that's one way. The other, and those are good, but they're not perfect. We run AI large language models across free form text. So any clients that we work with, if you're sending a message to your doctor or in a mental health app and you're journaling, we're able to actually look for high risk words, sentiment analysis. If somebody says, I'm in so much pain, I just don't want to wake up tomorrow, we're able to identify that in a proactive way.
I wanted to learn, like, how are you guys kind of figuring that out on a proactive way? Is that through an app, text messaging? Like, what is your way of
Yeah.
figuring out, like, hey, I'm having a bad day and this is not going well for me?
So we take what's called an omni-channel approach. So we're running those that suicide prevention large language model, which is proprietary to us, to across a slew of different data inputs. So we have a mobile app. We're also partnered with several apps that will have APIs that tie into that ping Vic, on a monthly basis. Hey, we're messaging you on behalf of your primary care provider. Just wanted to check in. How are you doing? And then you could fill that stuff out. If there's all the EHRs, the electronic health records have the patient portals, and you can go in and write your doctor a note in that. And so you might write your doctor a note saying like, I'm really struggling, and whatever, I'm feeling really down and depressed. I feel like I'm out of options. And they may get back to you right away. You might also write that to them on a Saturday evening or on a off hours where they don't get that to the next workday. And so we're running that analytics across all of that unstructured text as well. So does that address your question, Vic?
That makes sense.
And we're trying to do that and insert ourselves not as the direct to consumer play, like you noted, but where the patient or the health plan member engages with the health plan or the provider group. And so from an accuracy standpoint, it's not perfect, but the algorithms defer to being safe, you know, rather be safe than sorry. And so we get some false positives, but we're able to train the system and learn the system. If I say, man, after the Mets 10th straight loss, I just want to kill myself. Like that's not a real suicide ideation, as opposed to somebody that may be like has a gambling problem and they don't know how to there's no other way out of the debt that they have from gambling. We literally had that issue on the platform a few months ago. So how do we train the model then? We have healthcare professionals that we staff that will look at the positives to help train the model, and then the doctors related to the patients will confirm if it was a positive or a negative, and so the model is trained that way. The obstacle I was talking to you about was, for a long time, health systems and health plans would say they don't want to ask the ninth question on the PHQ-9, and they don't want to run the AI models because they were worried about what they would find, and there was a liability concern. In other words, they knew people were struggling and had suicide ideations. They just wanted to be more ignorant to it because then they weren't exposed to the liability. And man, like from a mission standpoint, that just always frustrated me because so you'd rather put your head in the sand and pretend that you don't know rather than try to be proactive in it. And so that's where we stood up a service in addition to our technology that we call response services, which are a team of social workers that will monitor the platform on behalf of our partners so that on nights and weekends, if somebody pops up as suicide, positive on a suicide ideation, we'll do a real-time proactive outreach and make sure that a safety plan is put into place and that we do a warm handoff for that person's needs. And it's been remarkable.
Interesting. And you were going to talk about a specific story that you were kind of
Well, that's what I
hinting.
was saying. The obstacles thing, and then overcoming those obstacles. I mean, we had health systems, so we like the tech, we like what you're able to do, but our legal department just won't approve it. And we went like 18 months with running into that obstacle one after another, and the response services was a turned out to be a really effective solution to overcome that legal barrier and get adoption of the tech and data.
Yeah. And kind of talking about your platform overall, I know when I was looking into it, you guys got around like a 510K exemption. I was curious how much that can potentially hold up on the regulatory side of things as AI moves deeper into risk stratification. A lot of health systems are potentially looking for AI vendors to, find these risks for many different diseases. What is your plan on that overall kind of, as more people are looking for these AI tools?
The way that we approached it is it all came down to what we wanted to claim and what we were saying the platform could do or couldn't do. And we're a decision support tool that is giving the providers and the care managers in the treatment workflow the data and the tools to make more informed decisions. But ultimately, the care decision and the what's the next best action is still up to the providers, and the diagnosis is still up to the providers. So if you think, we're not saying that, hey, Chris, it needs to be diagnosed with major depression. We're saying based on these data points and these stats, you might want to look at these different diagnoses, and then it's up to the provider. And so and maybe that's down the road, and we want to be more proactive in actually diagnosing people or treating people digitally, but we're not actually delivering care. We're not treating anybody through the technology, nor are we actually diagnosing anybody, but rather providing that clinical decision support angle implemented into the workflows. And as long the way the law is written today, as long as we stay in that, you know, clearly in claiming that very specific thing, we should be fine.
Yeah. One thing that you guys are very kind of, since you guys started, you guys serve so many different customers on the federal side with the VA, national payers, and health systems, of course. Those are obviously each one of those customer segments, I would imagine, has a different sales motion. How was the sales motion, for example? I'm very intrigued on, for example, the VA, because I know what they're known for being slow, very, very hard on sales cycles. Like I'm curious about how you guys landed those.
So, man, there's a lot to unpack there. But a lot of good, I think, fun answers. So first, you're exactly right. The sales motion is very different. But what's interesting is that the value proposition is very similar across those segments. Like each of those segments want to make sure that their people in their population are getting identified proactively for mental health, and that they're then routed to the right level of care, and that care, once it's delivered, is high quality, and the outcomes are what we want to see. That's consistent across any of the segments that we sell to. And so for us, the value proposition and the technology is very much the same, maybe with a few tweaks just in terms of where it's integrated and how it looks to the end user. But from an overall scaling standpoint, we're able to rinse and repeat a lot of it. But the sales motion is entirely different. And so we actually I couldn't figure out how to break into the VA and sell into them organically. So we acquired a company that at the time had a 17-year track record with the VA. It's called Capital Solution Design. So some brilliant engineers that were able to bootstrap their way into the VA and figured out and they created this highly integrated technology that was used by the VA nationally. And so we partnered up with them to say, look, you're brilliant engineers. We need you. You could help increase and enhance our interoperability capabilities. And we have a level of sophistication and growth and business development that we could expand the impact that you're making. And so that was our first acquisition 3 years ago. And it's been amazing. We've grown that VA relationship significantly. And from a business standpoint, we've actually broken out our go to market growth motions into what we call the public sector, which is federal government and state government. So Medicaid and federal government opportunities. That has its own chief growth officer. And then we have our commercial segment, which is health plans and health systems and providers, that has its own chief growth officer so that they can execute those different segments the way that they need to.
One thing that's very interesting on that is I feel like one, obviously, VA is such a huge deal and kind of goes exactly to your background specifically. And I feel like your background really helped a lot when it came to the sales motion overall on that end. But another interesting thing on the payer side is that you kind of ran a Blue Cross study, which is very hard to even get in general because, one is what's payer that went across. I feel like you showed a lot of amazing data through that. You showed better access, you showed better reducing costs, improving outcomes overall. I'm curious though, what did it take to kind of run a study like that with a payer? I assume it had to require a lot of trust, specifically maybe working with them over a long time now. And how And then I guess how much did you have to like I guess how did this case study help were for future sales conversations as well?
Yeah, and one interesting thing about this study too, the fact you noted the cost improvement, that's true. But one of the interesting things that we found was the outpatient behavioral health cost actually went up slightly because you were getting people to be outpatient behavioral health care that otherwise weren't getting to that care. But inpatient hospitalization costs went down and the overall medical costs went down because when they were getting the behavioral health treated, they showed up to the emergency room less. They were, they needed less surgeries, all that stuff. So we thought that was really interesting. Look, I mean, to do a study with anybody, let alone a blues plan, it takes time, it takes relationships, it takes trust, and it takes a belief that what you're doing is actually solving a real issue. We integrating mental health care and making mental health more objective is not a novel thing that's like this NeuroFlow unique statement that we're saying we can do that better than anybody. The data is resounding that when you integrate mental health and you make it objective, you get people to the right care, you're going to see those outcomes. So we weren't necessarily surprised by that. What we take ownership of is we're able to do that in a repeatable, scalable, and more efficient way for these organizations rather than doing it in a very manual process where you can never do it really with the efficiency that you need to make it available to everybody.
Interesting. One thing that you've kind of pushed upon, and it's very interesting and it makes a lot of sense, is that behavioral health moves forward because of value-based care and how that's very important. And even though a lot of, I guess, behavioral health is still fee for service, I'm curious to know, like, are we going to that right direction for in BBC, or is this still something that's just, stagnant? What is your take?
Yeah, I you can't do value-based care without behavioral health. I mean, I'm a very firm believer in that, and I am very comfortable saying in that in such an absolute way. Because if you're at risk for somebody's, I don't know, say they're if somebody's struggling with diabetes and you're at risk for their cost of care and you don't have a handle on their depression, that person is going to eat less healthy, they're going to exercise less, they're going to be less adherent with their medication. And that all of that is going to impact their diabetes and going to show up to the emergency room more, they're going to have more inpatient, they're going to have more complications and all that stuff. And so it's a paradigm shift where when you're talking to a medical provider and they say, "Oh, I'm not a mental health specialist. I don't treat mental health." Then you're not treating mental health. You're treating mental health in service to the diabetes. It's treating the overall diabetes, not just the physical nature of the diabetes. And so I think that there's been more of the industries recognize that more and more, and you see that by these shifts in policies. And I'll give you a perfect example, and this speaks to your value-based care question. CMS changed the Medicare star ratings this year that they take effect in 2027, where for the first time ever, depression screening and importantly, the 30-day follow-up for positive depression screening is going to be a key rate towards the star ratings. And never before was that ever like the depression and the coordination to depression ever impact star ratings, which has a direct impact on revenue and bottom line for these health plans. And so I'm very optimistic that between policy shifts, the administration, and the way that the providers are finally recognizing the integration of mental health and physical health and really achieving value in doing that, we still have a lot of work to do, but it's
For
more
sure.
today than ever before.
Absolutely, I agree. On that case specifically, I wonder how many patients are actually getting referred, I guess, to a psychiatrist from their primary care due to any mental health issues versus, because you mentioned a lot of PCPs are diagnosing or not, they get a lot of patients with, mental health. How many are actually getting referred to a psychiatrist, if a lot? And do they actually know how to proactively care for their patients over time?
I think it's impossible to know how many get referred because sometimes the referral is, hey, go call this card, or but what we do know is that of the of the people that have mental health diagnoses, roughly 2/3 of them never get it treated in a mental health setting. So that's a huge gap, right? And then, by the way, not everybody needs psychiatrists that are part of that, right? Not everybody needs medication. If you struggle with
Right.
depression,
Absolutely.
it's not like depression is a binary thing. But if you're sending everybody to the psychiatry department, that's where you get a bottleneck. You get long wait times. We worked with one health system where the wait times for psychiatry were 51 days on average.
Wow.
Think about
What?
if you're struggling with depression and you're telling me I have to wait 51 days, that's just going to exacerbate the issue. But when you're able to be, for lack of a better term, like an air traffic controller and get the right people to psychiatry and send other people elsewhere, nobody's falling through the gaps, but they're all getting the right level of care. When you do that, we were able to reduce that wait time down 51 days to under a week on average. Most cases happening within 24 hours. And when you do that, the outcomes just speak for themselves. And not only the outcomes on the mental health side, right? We're not just talking about you're seeing an improvement on the depression, but going back to this integration premise, you actually see an improvement on their A1C level for diabetes. You see cancer patients recover faster post treatment when their depression is handled. You see hypertension patients numbers improve. You see obesity patients lose weight and you know, just across the board, when mental health is treated effectively, it impacts the overall health, not just the mental health side.
Absolutely. 100%. And one thing that's very interesting on you guys specifically is you've done multiple acquisitions. We were talking about one of them earlier with the BA, Owl Health, Quartet, and all of these guys. Why? How do you know when to acquire versus just to build it instead? Like, if that makes sense. Like, how did you figure out? Okay, this is better. Maybe it's due to the connections, like the BA, or why don't we just build this out with our team and maybe potentially just build it to our customers and get
It's the one of our early employees who was with us for 8 years. She was chief product officer that is off doing great things for herself as her own entrepreneur now. It what gave me a really great lesson learned in that whenever making decisions about like how we want to approach something, there's the iron triangle. It's time, resources, and scope. So we have limited resources, right? I can't hire. We only have so many resources that we could hire. I can't hire 1,000 people overnight. Time, it depends on how fast I want to get there. Like, am I willing to wait 3 years or do I want to get there in the next 6 months? And scope, is it something that is like pretty easy to develop, or is it something that we should just buy and partner with? Or because it's going to be more complicated and there's something that I can't just engineer myself. You take in those three factors, and those are the variables that we take into account while we're figuring out, do we want to organically build it and grow, or do we want to grow through inorganically through acquisition? And look, the VA is a good example of I could have, I would have eventually figured out how to get into the VA, but at
right.
what cost and what time? You know what I
Yeah.
mean? And so we had a really great group of engineers that had a solid product that had great reputation, and they were already in there. So I was able to speed that up so much quicker than continue to toil on our own with that. And the same thing with Quartet brought the amount of talent that team had and the some of the data assets that they had, and they had payer relationships that a payer sales cycle is anywhere from 12 to 24 months. The fact that we're able to get into those clients in a much quicker way just helps us make the decision on whether we want to do it on our own or with our new partners.
Interesting. Yeah. I mean, one thing that's kind of very interesting now is like the health plans are now, I feel like when I speak to a lot of payers, one thing is we're looking to build our own or they want to own their own AI models for behavioral health and stuff like that. Obviously, you guys are working with them, kind of quote unquote consulting on that end. Do you think at one point maybe payers are going to come to you and say, hey, we want to own specifically your AI model for our members? Or do you think it's just going to be like, hey, we're going to keep partnering with you guys and obviously serve different health systems and things like that?
Yeah, we've taken the approach of we want to be that infrastructure tool for them, not this point solution. So we've taken the approach of, if you want to build on it and have that be yours, you can do that. We'll give you, we have APIs that allow them to do that. what I think we bring to the table that's really hard to replicate for any payer is the benefit of having our universal data set that they could continue to train off of. One of the other acquisitions that we did was an IP deal with Intermountain Health. We acquired some of their owned algorithms and all of their data de-identified data sets. But our models now are trained on those as well as other data, and any plan that ties into our system is able to have the benefit of not just using their data, but learning and training off of our universal BH data set, which I think is really, really valuable.
Yeah. I mean, your origin story is about veterans falling off the track pretty much through the cracks overall. And that's kind of speaks to about how you've kind of gotten to the federal works, the VA contracts and things like that. All of it makes sense. But why go specifically, I guess, for the federal work when it's obviously, as we were talking about, slow, brutal, a lot of heavy lifting, when you can just, I guess, go to the commercial market and just make much more or for your business specifically, and which you are doing,
Yeah.
obviously. But like, why go also to this long, different, I guess, route as we were talking about?
Well, we didn't do that the public sector first. That was a growth path that we grew into once we had a strong foundation and foothold in the commercial sector. And so I totally agree with the notion that it would be ill advised to try to do both all at once, right? We wanted to focus on the commercial sector first, but a few reasons why go to the public sector and not just focus on the commercial sector. One, my personal mission and reason, my why for the passion of what we do every day is unavoidable. And I love being able to go back to the military and the VA and work with them as a partner. But two, the there's 7 million veterans at the VA that struggle every year. The need is tremendous. And, from a mission standpoint, we're not in this just to build a big business. We want to make an impact. And I think both the commercial and the public sector enable us to do that in a more scalable way. And then last I'd say is for all the toil and trials and tribulations that it is to get into the federal business, you're right. It's not for the faint of heart. When you do it well, which I would argue we have now based on our growth in that segment, it's such a competitive moat because that difficulty to get into that market exists for everybody else. And now we're a really ingrained partner with them. And so from a business rationale standpoint, maybe hindsight's 2020. If it didn't work out on getting in the VA, the answer would be, it wasn't a good idea. We shouldn't have tried it. But since it has worked out, it's easy to say that it made sense to do that. But I'm glad it has to this point.
Behavioral health has such a big two-tiered problem, right? A lot of patients can't afford something that, for example, meds. We're talking about, the lack of, patients just getting prescribed meds when they can just maybe take a more holistic approach and kind of focus on their health and what they can actually maybe potentially do without it. And a lot of, obviously, as we were talking about, few providers don't really focus a lot on that approach. Where does I guess, the identification and triaging kind of model actually bend the curve for a lot of, I guess, patients when it comes to booking appointments? And when does, like, for example, when does it come to a point where patients at one point, are going to start fully focusing on their mental health and their approaches and using you guys much more, I guess, frequently than now and in general?
Yeah, patients or providers or both. What's the
Both, I would say. Like, if like providers and the patient route.
Yeah, look, I think the recognition that it's not just mental health is treated over here. Like you get your physical therapy and your knee replacement, or your physical health issues over here, and then your mental health's over here. It's just one system. One impacts the other. And the more that we understand that and recognize and appreciate that, the more it's not going to be so apropos to say, "Oh, I need to go to get my mental health treated," because just like my physical health, I need to invest in it. Otherwise, it's going to impact one or the other in either a good or bad way, depending on where, if I'm getting it treated. And I think the more that we could demonstrate that with objective outcomes, which we're doing, the more that you drive that change. And from a triage standpoint, that's key because again, nobody wants to go to a psychiatrist and wait 51 days to get treated, if you're going to be frustrated and give up. Like, I'm done. But if it's a better experience for you, because when you need support, you could actually get the support that you need, and we're able to do that because we're using the resources that we have more effectively. I think that's what ends up reducing that frustration, improving the experience, and ultimately then getting better adoption of those services, which will then yield the outcomes.
Yeah. A lot of I'm curious, a lot of patients that use your app, what kind of mental health conditions do they kind of come in with? Is it mostly depression, substance use disorder, opioids? Like where does it mostly lie on the spectrum?
Well, so if you're thinking about, we have a mobile app engagement platform we call Onward, which provides digital self-service tools like cognitive behavioral therapy and so forth, and that's really meant more for your mild cases and situations, and that's mild depression, mild anxiety, maybe mild alcohol use disorder, things like that. But the system overall and the data and the triaging and then the care navigation is everything from a non-diagnosable mild case of anxiety, just like maybe I'm stressed out because it's final season in school, or I'm stressed because of it's the end of a quarter at work or something like that, to everything from the more serious SMI issues like major depression, treatment resistant depression, and then everything in between: substance use disorder, whether that's alcohol or opioids, depression, anxiety, PTSD. We do a lot of work with women's health and postpartum depression. And the idea of that is that because we're not providing care there, we're not a specialty clinic that's saying we specialize in PTSD. What we're doing is we're saying we could identify that person with PTSD and make sure they get to the clinic that specializes in PTSD and do so in a timely manner.
And a lot of you know a lot of patients obviously that are or a lot of patients and anyone in general using your app and finding a lot of like making it much better than for themselves and for everyone around them. How can you kind of share like any impact stories that you've kind of heard from many other patients that you've worked with along the way of NeuroFlow?
Course, I mean, from a platform standpoint, the amount of lives that we touch on an annual basis still, it makes me proud, but it also reminds me that when we have tens of millions of people in this country that struggle with mental health, and those are the ones that we know about, we still have a lot of work to do. And, we, in a lot of cases, our app is not even deployed out there. I mean, we're a white label solution. If you're a veteran and you go to the VA and you get those questions asked to you, that's happening through our technology, but it doesn't look like us. It's branded like the VA, all that stuff. I gave you some macro examples about reducing the cost of care and stuff like that. But I mean, we had a suicide detection a few weeks ago for a father that was struggling with depression, that tried to get an appointment. We learned this after the fact. Tried to get an appointment, was told that there was a 30-day wait time, felt helpless, and didn't know where to turn to. Our algorithms picked up that he was really struggling, and we did a proactive outreach, and we're actually able to get him into an appointment by the next morning for somebody with a provider that accepted his insurance. And because then we send that feedback loop back to his providers. He's not falling through the cracks. People are following up with him, checking, are you doing all right? How are you doing? All that stuff. I mean, I don't think it's melodramatic to say I think we saved a life there. And if not saving his life, he was going to show up at the emergency room. His physical health was going to suffer. And so that's an anecdotal N of one, but that's what happens, I think, when you pair high tech, high touch with our mission, the impact that you can make.
What is the plan for NeuroFlow for the next like 5, maybe 10 years? Because obviously one thing is obviously, as you mentioned, there's a lot of work that needs to be done, a lot of patients, a lot of people. I mean, everyone kind of struggles with mental health. I mean, whether they admit it or not. What is the kind of big plan here for NeuroFlow as we kind of progress?
Look, I think mental health is unique because it's the one specialty that impacts every other specialty. We're talking about this integration of physical and mental health. There's a famous report that Milliman did that showed the cost of patients that had chronic medical conditions. I think they listed out 20 or so of them, hypertension, diabetes, so on. And then the cost of those patients if they had the chronic medical condition and a corresponding mental health diagnosis. And the untreated mental health caused their spend to be 4 to 6 times more expensive on an annual basis. And that extra cost was not because of mental health costs. That was again because of the physical health outcomes. And so we 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 don't want to be a mental health company. We want to be a total health company that integrates that and makes mental health ubiquitous and just standardized, and regardless of where you're at or where you're getting treated and so forth, and meet everybody where they're at to fill those gaps in care. And that's a audacious goal, but if we even achieve a fraction of it, I think we'll make a big impact.
Absolutely. And in that, case specifically, is there any way how NeuroFlow can potentially integrate, or maybe you guys already are, with a lot of different, maybe having, for example, with the suicidal incident that happened weeks ago, having providers on staff ready to go on your team and kind of contributing on that kind of category for maybe telehealth and stuff like that? Is that any avenues that you guys have kind of seen as well, or maybe integrating with maybe, and I know you guys kind of do telehealth, kind of work with a lot of telehealth practices or telehealth payers overall. What does that kind of look like, overall?
100%. So we partner with those telehealth providers and make sure that we're getting those people to those providers at the appropriate times. And that not only are we getting them to them, but then giving those providers some insight to say, hey, this is why we're sending this person here. Like, so they're not starting at ground zero with them. They're starting with some information in terms of what the next best action for that referral is. And so we'll continue doing more of that. Whether or not we get into the direct care business, yeah, right now our focus is on creating the best in class technology and data platform to support that care delivery side. But yeah, I mean, vertically integrate ourselves with care delivery obviously could be an option, but that's not a focus of ours right now.
Where do you see mental health looking maybe in the future? Do you think the future looks bright? Do you think there might be, obviously we can't predict because anything can happen, for example, COVID. Where do you think we're going in, I guess, state of America, state of the nation, I guess, a globe in the world when it comes to taking care of ourselves and kind of making it more proactive?
I'm really optimistic. I think if you just look 20 years ago would have been way too early. Nobody accepted that mental health was a part of physical health. It was always treated separately. That is now that's the standard, not the exception, is to recognize that connection between the two. And so great, we recognize it now, we appreciate it, but there's still plenty of people that fall through the gaps. And so it's a matter of now filling those gaps. And that's a combination of policy shifts, payment shifts, that's the value-based care discussion, that's using tech and data and meeting people where they're at. And we're just at the beginning stage of that, which is exciting. But I don't think it's going to be. If I had to guess, in 15 or 20 years, it's not going to be mental health or physical health. It's just going to be health, and there could be a specialty just like any other specialty.
Yeah, for sure. Quick rapid fire here. Are you ready, Chris?
Let's go.
So if you were kind of starting NeuroFlow from scratch today, what would be the first thing that you would do differently?
I would learn the economics of healthcare more. I mean, it would have. We spent 2 years working with therapists, which were great. I love therapists, but we didn't understand the economic incentives and to really drive adoption and the change. And once we understood cost of care and claims and value-based care is what enabled our rapid growth.
Yeah. What is one healthcare trend, a lot of founders are overestimating, and maybe a couple or one that they're underestimating?
I think everybody's overestimating is going to replace everybody, and going to replace therapists or going to replace doctors and that sort of thing. I don't see that happening, at least in our lifetime. I think AI is going to be a really awesome tool that's going to allow people to be more effective and efficient and avoid obvious gaps from happening. I think people are underestimating the need for or the ease of interoperability. Right? We're at a state that we have a lot of we have a lot of disparate point solutions and we have a lot of different EHRs. And when the systems don't talk to each other and share data effectively, it creates more of a burden on the providers and the nurses and so forth, which then impact adoption and so forth. So we have to get a handle on interoperability and making that smoother for the providers. And I think we could do that, but I think people underestimate how difficult that's going to be.
Yeah. During your military days, what were the most memorable moments you've had in Iraq and all of these places?
I would easy one there. I mean, just getting to lead soldiers. These are men and women that literally would die for you, and we get to solve some of the hardest problems in the most austere environments I've ever been, have lived in. Walking away from that, getting to call these people friends for a lifetime now and stay in touch with them and support them even post uniform has been an honor of a lifetime.
What was the hardest decision you've had to make so far as a CEO?
Anytime we have to make a personnel decision, it hits home. It hurts. Even if it's for performance issues or something like that, it's just because it's like, what could have I done to train that person better or set them up for success more? Again, maybe it's the military background, but all a company is a combination of people working together to solve tough problems. And so people is everything. And I take each one of those decisions really tough.
Yeah, I bet. I mean, I feel like, hiring is such obviously a hard thing to do and in general. And, we always definitely have to make, some mistake. We always make mistakes along the road. And, as a founder, you make so many. What was one lesson about actually, what was one lesson that you kind of learned, I guess, about hiring that every, I guess, first time founder should kind of learn, something that you learned the hard way?
Assuming that you're aligned with somebody in terms of expectations and so forth, and not being more explicit and direct. If we hired somebody that came from this big company, like huge national 50,000 person company, and we hired them like when we were like 50 or 60 people. I should have been more explicit. I assume that they knew what it would be like to join an early stage company, and it
Yeah.
just became very clear that they didn't. And we could have sussed that out in the interview process.
Yeah, very difficult. Yeah. A final question here. What was the best advice you've gotten that you did not listen to?
But that's a good question. Best advice, I guess the implied part of the question is, in hindsight, you wish that you listened to.
Exactly. You wish you listened to it, but you did not.
I guess we'll stay on the theme of people here, personnel. I mean, I would say again, when you're in the thick of it, you're in the trenches, and you have to make some of these tough decisions. There comes a time where you realize that something just isn't working out with somebody. And the advice was, when you know that, it's time to make a change. And but we didn't listen, and we held on for too long. And in hindsight, it's better for us as a company, and frankly, them too, right? Because if they're not succeeding here for whatever reason, it's not an insult to them. They're smart people that could be successful elsewhere. And so making that change you know, when it needs to be made versus trying to hold it on and fix it.
Yeah. I mean, curious question here. A final question, I promise. Did you guys hire any military, ex-military people as well to your team? Due to your background, they probably could have been attracted to what NeuroFlow is doing. And how much of an impact did they make potentially to your team?
Yeah. No, well, not only to the team, but several of our investors are veterans. Well, yeah. And yeah, we have a whole cohort here. We have a Slack channel, Veterans of NeuroFlow. So I think maybe rough 8 or 9% of the company are military vets, and we share war stories and kindred spirits, but they're just a part of the team like everybody else.
Of course. Dude, it's amazing to have you on the show. Thank you for being here. I truly enjoyed this so much. So thank you again, and I truly appreciate it.
Thanks, Vic. Keep killing it.